Bill Zogby. I'm the incoming president of the American College of Cardiology, and I'd like to welcome you to this press conference this afternoon. I think the topic this afternoon is very dear to my heart, since indeed the theme of my presidency year would be about patients, patient-centered care, and how can we improve patient care in an environment that is changing, at times challenging. But I think if we focus, in my opinion, on the patient, I don't think we will be losers. Actually, we're always winners. So I want to congratulate first all the authors that will be discussing their topics this afternoon, because they've tackled this, and actually we will share read
appropriate drug up titration and decreased 30-day and 6-month readmissions. This translates in providing better quality of care and potentially decreasing the burden on our national deficit for heart failure. If broadly adopted, this may translate into saving millions, if not billions of dollars spent by Medicare every year. And we have shown that the one-on-one counseling with the use of the checklist about heart failure education, monitoring information is much more effective way of delivering heart failure instructions. Thank you.
Thank you, Dr. Basur. Next is Dr. Val Rakita, internal medicine resident at Temple University Hospital, who is presenting effects of blood pressure self-measurement and telemedicine communication on physician prescribing habits. Dr. Rakita.
Good afternoon, everybody. Thank you, Dr. Zogby. Thank you to the ACC. It's truly an honor to be here. Like Dr. Zogby mentioned, the title of our study is called The Effects of Blood Pressure Self-Measurement and Telemedicine Communication on Physician Prescribing Habits. This was a retrospective of 241 patients selected from a large urban environment, not much unlike Chicago here. Patients were deemed appropriate if they had high blood pressure, defined as 150/90, and no obvious cardiovascular disease. The original trial actually looked at telemedicine versus usual care and to see if it would affect blood pressure. The secondary analysis was more focused on looking at telemedicine and blood pressure measurements on physician-prescribed habits. So the patients in the telemedicine arm, they had baseline vital signs done and blood work, and they entered the study for 6 months. Over the course of the study, they were instructed on how to use the internet program to enter those results of their blood pressure, steps per day, and their weight. Those results were then faxed to their primary care physicians once a month, and reports were sent to them as well, and they were instructed to bring those results with them to their family care doctor visits. Nurses kept track of these results, and if blood pressure values were consistently high, they were told to communicate this with the patients with facts about blood pressure and to bring this up with the physicians. The patients in the control arm had the same basic demographics done at the initial study, and then were told to see their doctors and no other intervention was performed. After 6 months, we repeated the vital signs, the blood work, and questionnaires to see if there were any differences in blood pressures or the medications that were prescribed to the patients in the telemedicine arm versus the control arm. What we found was that there was a statistically significant change in the amount of antihypertensives prescribed to the patients in the telemedicine arm compared to the patients in the usual care arm. This change was about 6%, meaning patients who started the study had about 2.2 medications prescribed to them to lower their blood pressure and ended up with 2.34 medications prescribed, as opposed to the patients in the normal, usual care who did not notice any change. And in fact, there was a trend towards a decrease in the amount of blood pressure medications prescribed to them. So in conclusion, we know that cardiovascular disease is the #1 cause of mortality in the United States. And hypertension, high blood pressure, is one of the most important factors that contributes to people's cardiovascular risk. If there was a way to implement a system to decrease people's blood pressure, aside from lifestyle changes alone, we know that the pharmacotherapy can decrease people's blood pressures and therefore decrease their cardiovascular risk and prevent mortality. Thank you very much.
Interesting. revisit to the...
It's relatively 5 pounds.
Sure. So the particular subgroup that seemed to fare better in terms of blood pressure control in the telemedicine arm was a non-diabetic subgroup. The reason we think that was true is because diabetic patients typically have more medical complications than the average patient, whether it's going on hemodialysis or visiting their doctor for blood glucose visits. So they're already in the medical system and seeing doctors much more often than the typical patient. It's those people that are non-diabetic that don't have access to that. When you allow them to incorporate their own blood pressure control into their daily lives and enhance that physician-patient interaction that they don't get to be a part of because they don't have those serious comorbidities, they're the ones that benefited most from the self-blood pressure measurement and then the telecommunication with their physician.
Do you have plans to continue following these patients, or is this study ended?
So this particular cohort is finished, but in the future there will obviously be plans to improve on the system, to expand it, and to apply it to people who we think would benefit more from it.
Dr. Basour, is the copy of your checklist available?
Could be conceived of because
Increase isn't due to refractory high blood pressure to one of those or two of those medications. The next step is to either increase the doses or to add more blood pressure medications. So with the goal being to reduce the actual blood pressure, the more medications you can give, conceivably will decrease their blood pressure, and that would help them in the long term. There are, of course, side effects of every medication you give, so you're always weighing that versus lowering their blood pressure. But in the end, our goal, at least for this study, and to reduce cardiovascular risk, is to decrease blood pressure with the addition of additional pharmacotherapy. Okay.
Dr. Wright.
Janet Wright, Million Hearts. Although I enjoyed reading of all of your studies, I'm particularly interested in yours, Dr. Rikita, because Million Hearts is laser focused on improving the ABCs, aspirin, blood pressure control, cholesterol management, smoking cessation. So I wonder if you'd comment on this phenomenon of therapeutic inertia, because I believe that's what your study helps us address, the lag between the identification of the blood pressure that stays elevated over time, trying to treat it in an office visit as opposed to being in more continuous contact. And then I want to know, you referenced the economic benefit. I wonder if you've done some numbers on what it means to improve the control of blood pressure. My understanding is we've got 65 million people with high blood pressure in the country and 37 million uncontrolled. So have you looked at the cost of doing what you've done wide scale? So thank you for both questions. The latter question, the cost has been not directly looked at by our study. I researched this in the past to see if other people have looked at the cost of setting up these telemedicine systems and the cost versus benefit ratio of treating the hypertension with its use. And unfortunately, no figures have been ever released because most of the cost and the benefit is derived from preventing the end results of hypertension, which is real cardiovascular disease, the heart attacks and the strokes and the kidney failure. And those studies would take a lot more time, and no one's even started to look at whether telemedicine will affect those outcomes from happening. That's where you see most of the savings. So any preliminary short-term outcomes of reducing someone's blood pressure won't necessarily result in any cost benefit yet until you look at it many years, potentially decades down the road, when they stop getting heart attacks and stop getting bypass surgeries. And that's when you would see the true benefit of incorporating a cheap telemedicine system and preventing very expensive operations or doctor's visits in the road. I'm sorry, what was the first question? It was about your comment about how this approach could reduce the cycle of titrating medications. Based on our current model, it only happens in an office, and there's data to support the idea that blood pressures stay elevated over time, that we're not getting people under control as quickly as we could. Your study seems to indicate there's another pathway to quicker control.
Right. So the idea is that people who visit their doctor's office once or twice a year only have one or two data points, and they may not be representative of a person's true blood pressure. If you allow a patient to take part of their own care and to take their own blood pressures at home, to visualize those numbers, and then to communicate those numbers to their physicians, you have many more data points to work with, so you can trend these numbers to see if you truly need to increase or decrease their blood pressure medications, and kind of catch the disease before it gets out of hand. So the clinical inertia you can kind of take advantage, because you have patients who are incorporating their own healthcare into their lives and enhancing that communication and relationship with their physician, ultimately leading to these benefits down the road.
Thank you.
Sure.
Thank you. Any other questions? If not, I want to thank our speakers for their exciting studies, and thank you, the press, for being here, and thank Dr.